Good morning. I'm Dr. Larry Patterson, Medical Director, Eye Centers of Tennessee, and with me this morning I've got two guests. I've got Dr. Danica Morelli of the University of Houston College of Optometry and Shalini Sood of the Cleveland Clinic, and we're going to talk about some of the challenges facing optometric and ophthalmic practices and how innovations in eye care are helping to streamline practice efficiency and deliver better care across the whole continuum of care. So we're going to start with just practice efficiency in general. And I'll just ask y'all, what technology, what innovations have you adopted in your practice, and how has it impacted that efficiency? And give me examples of that. Dr. Morelli, I'll start with you.
Sure. Thank you for having me. Most of the patients that I see are glaucoma patients or glaucoma suspects. And then I see a handful of retina patients as well. So we have Humphrey field analyzers. We have some of the older ones. We also have the HFA3 with the 24-2C. We have a Claris fundus camera and a Cirrus OCT. But probably the biggest practice change for us was adopting Forum, where we really can just sit at one table and look at everything all together, manipulate GPAs and that sort of thing.
I, I just, when people bring up Forum, I'm so happy you do, because that has been a game changer for us at all as well. And I think a lot of people are not even aware of its existence. We may talk about that more. Dr. Sood?
Yes, thank you again for having me this morning. I agree with many of the things that Dr. Morelli mentioned. And similarly, Glaucoma Workplace has really impacted, the efficiency and my communication with my patients. So my background is that I'm a glaucoma specialist at Cleveland Clinic, and I've been in practice for over 15 years. So I've seen the evolution from my fellowship days of paper charts and having to flip through those charts and pull all the visual fields and compare them, to now being able to rely on OCT, as well as our visual fields and the advancements in the different testing patterns that we have now available to us, that have made us more efficient. And just kind of the integration of all of that at the Cleveland Clinic. After radiology, we are the department that has the second most amount of imaging. So I think we forget when we're in the eye field how much data we're collecting every day. And it's very overwhelming, and not just for us, but also our patients, and trying to interpret what all of this means. So having something like Forum really does help us streamline that information in our delivery to our patients as well.
And this is, I'm entering my 35th year of practice, and it really has changed. So, speaking of that, Dr. Morelli, I mean, OCT wasn't even around when I started out. We'd never even heard the name. So, how has that aided in the diagnosis and management of your glaucoma patients? And tell us specifics, features, or something you learned. How do you use all that data?
It's so interesting. So I've actually been practicing for 31 years, and the idea of OCT, never even came into our minds when I was first starting. And then we went through time domain and now spectral domain, and even further generations of OCT. And it's really just amazing to think about the detail that we can get to and looking at nerve fiber layer loss. And then, I think even more recently in the last 10 years, say, the recognition that macular scans and ganglion cell interplexiform layer information could even help us make the diagnosis earlier. It's really been a game changer. I do think there's always sort of a cautionary tale, though, right? I think there's a tendency to think that the OCT is the perfect answer. And realistically, it gives us information, but we still have to use our doctor brains to figure out what that information means. And I teach students, so that's kind of the world that I live in. I always remind them, not to relegate their clinical exam of the optic nerve to an afterthought. It really has to all make sense, the visual field, the OCT, and the clinical exam as well.
I think that's a powerful point. Dr. Sood, let's switch over to visual field testing, and that tends to take a lot more time, effort, energy, patience than some of the other diagnostics. So what innovations in technology have enabled you, let's just say, to reduce the testing time and improve accuracy and help give realistic, helpful tracking of the disease progression.
Yeah, absolutely. So, as Dr. Morelli was mentioning, there's the OCT, and um, but we definitely still rely on our visual field, even though our patients dislike the test. They're always dreading the days that I'm telling them we have to do a visual field test today. It has gotten a little bit easier. I will say that the pandemic, we had adopted the HFA3, and especially during that time, we were very nervous about the time being spent for the safety of our patients, for the safety of our staff. And so this is the time that I kind of decided, okay, I'm going to switch from the CETA standard, which I've been very, accustomed to using, and the highest standard for us. And I embraced the idea of starting the CETA faster, and specifically the 24-2C. So the CETA faster decreases the amount of time from the standard about 50%, and from CETA fast about 30%. So we're going back down to about 2 to 3 minutes per eye. This is extremely helpful, not only for the workflow for our patients, but the anxiety that's created when a patient's taking the test. Our patients are much older. Um, we are getting more reliable tests, and oftentimes I would like to see, as we know, 3 tests confirming that a defect is real. And can you really imagine having a patient coming back 3 times, even in a year, to do CETA standards? Not really, but now that I have the CETA faster available, it's a much easier conversation saying, okay, we just need to have you come back, and we're going to do this test again so we can confirm this is real. We can make decisions on our treatment plan based on this. And then specifically the 24-2C, which is very unique. Again, Dr. Morelli mentioned that we're now looking more at the macula as being able to detect earlier changes. Well, that's not only in the OCT, it's also in the visual field. So there have been studies to support using the 10-2 algorithm to detect earlier changes, especially in the central area. With the 24-2C, it takes 10 of the most commonly impacted points due to glaucoma defects and adds that into our traditional 24-2 testing. So you can almost think of it as a hybrid of the two. And instead of having to do 2 tests, the 24-2 and the 10-2, you can now do it in 1 test and get critical information in
Mhm.
our diagnostic abilities.
That's really helpful, and that's news to me. One of the things we've been doing is trying, when you see that patient and you say, okay, next time we see you, it'll be time for the visual field test, and you see them wince, I tell them, it's not a test. I don't know why we even use that term, but we all do. I just tell them we're taking a measurement. It's when
Mm.
nobody wants to take a test,
Right.
we feel like we're being graded, and you're not. We're just going to measure how you're doing. Dr. Morelli, we've talked about, especially in your field, a lot of the glaucoma technology. What impact have you seen this have on your patient's experience, and has it supported better managed care, collaborative care? I'm sure you work with other doctors. How's that all worked out for you?
Certainly we do. I think that, for the patients, from the patient standpoint, like Dr. Sood mentioned, I mean, they sometimes they won't come on the visit that they know they're going to do a visual field. Patients just hate to do it. And telling them, look, we have this new technology. It's going to help this test run much faster. I would say, I think you have to tell your patient, like, kind of hold on and really pay attention, because those first 30 seconds are really important in that CETA faster test. But if you have the right patient, if they can really kind of get into that test very, very quickly, the CETA faster really can be so they really just don't dread it as much. So that's really great. And so I think that patients appreciate the technology. Patients appreciate that we're trying to make things better for them and reduce some of the hassle of taking that visual field. What'd you call it? I can't remember what you called it,
I,
but
I just call it a measure.
measurement, visual field measurement. But related to your question about collaborative care, I can remember where if you wanted to look at a series of visual fields, you print out this thing. It looks like the Dead Sea Scroll, right? It's 25 feet long, and you can't really fax that over to another provider or whatever. And so, being able to print out either a single page or a 2-page GPA visual field, and the same with the OCTs, and get that over and really show, what's been going on. Why am I sending this patient to a surgeon now? Oh, well, you can see that they were stable for a while, but recently they've started to, take a turn for the worse. And so having having that data so easily available and so easy to read, so easy to interpret, has been really helpful.
Dr. Sood, um, if we took our doctor hat off and put the patient hat on, how do you think the patients are viewing their experience with you, and sort of what steps have you taken in your practice to enhance their perspective? Because at the end of the day, even if we're doing everything perfect, if they hate the experience, they're not going to come back.
You're absolutely right. I mean, especially with our glaucoma patients, it's a chronic condition. So oftentimes, I'm the doctor they're seeing more frequently than they're seeing their primary care doctor. They may be seeing me 3, 4 times a year, and for their lifetime. And then I start seeing their family members. So it is really important, even though we're trying to be efficient and the number of patients we need to serve continues to increase as glaucoma becomes more prevalent. We really have a very small window to make that connection, that relationship, and gain their trust in us treating their disease. As we know, it's a silent thief of vision. And, if we can't build that rapport, they don't understand their disease, then they're not going to be compliant. They're not going to follow up. And so, as we were discussing the imaging and forum, I found that that has really helped me in the patient education portion. I, swivel my monitor to the patient, and not only the patient, but the family members, partners, because they're very involved as well, because they're their caretakers. And I can show them this is the trend analysis. You can see where your visual field was 5 years ago. You can see where we're going right now. You can see that defect right in the center, and this is why you're not seeing as well. Or look at the colors on the OCT. This is looking at the health of your nerve and how things are progressing. It's not infrequent where I have a patient comes in and they've been seeing somebody for glaucoma, and they say, I've just never understood it before. No one's ever showed me what this means. So I think it's been so critical to my patient's experience, and I think this is why they feel more invested in their disease, and what can they do to make to help keep things where they are.
Dr. Morelli, let me switch gears just a little bit. We've talked about us and the patients, but at the end of the day, especially after this pandemic, we've all had some problems with staff and staffing shortages. And at the end of the day, our staff needs to be happy. So, what do you do to prepare or train your staff so that they have what they need, for them to have a good day at work as well as everyone else?
Yeah, this might be a better question for Dr. Sood because most of my students are doing the testing, right?
Ah,
So the students are almost acting as the technician. But what I would say is that I talk a lot about OCTs in continuing education lectures, and one of the things I'm always surprised at is that people will say like, "Well, how do you teach your staff?" And I say, call up the manufacturer and have them come teach your staff, right?
yeah.
Good training, having websites and tutorials and things that help them be able to understand and troubleshoot, having good service. When something is going wrong with one of our instruments, my main tech picks up the phone and gets somebody on the phone, and it's solved. And so I think, I don't have a lot of staff. My students sort of act like my techs, but having that training is really important. I think ZEISS does a great job of that.
Yeah, and I might throw in that's another, whether it's ZEISS or any other larger company, it's something has something to say. What are the advantages of getting your equipment from a well-established company that has the depth and breadth to be able to handle that? Dr. Sue, do you have any comments on that? Because, like she said, you've got a big clinic with lots
Yeah,
of
we
stuff.
have, right. And we have many times we have to rely basically on the industry that's providing us this amazing technology, especially as we transition to the HFA3. That was a big change, and but it was very welcomed. Like I was mentioning before, we just have such a high volume, not only with our glaucoma patients, but all the cataract testing that we have to do.
Hmm.
So
Hmm.
the fact that we were able to cut down on the visual field testing by switching over to the HFA3 and the 24-2C, the faster portion, has really helped in the workflow. Obviously, OCT continues to improve and become more efficient, but overall, I think that just having the support from ZEISS, and even as a physician, the glaucoma workplace, it's there is some nuances that you need to be walked through. And the ZEISS team has been very helpful whenever we need, a group tutorial to get online and work with us as much as we need, and always available for any questions that we have about how to optimize our use of this technology.
All right. Well, I've got just one last question. I'll just ask you both for sort of a closing comment. If you combine this better practice efficiency with this technology, we're enhancing our patient and hopefully our staff and provider experience. What impact is that actually going to have on the outcomes? Start with you, Dr. Morelli.
Well, obviously, when we have patients who can stay awake during a test because it's shorter than the previous test, when we have the ability to see subtle changes where before, through form, for example, where before we may have, or GPA even, where we may have used to have to eyeball things to try to figure out if things have changed. I think everything is looking at earlier intervention. And it all just works so well together to make the doctor happy, the technician happy, the patient happy. It's really, I think about the way that I practice glaucoma now compared to, say, 1992 when I graduated, and it's really completely different and so much easier and better.
Dr. Sood?
Yeah, I mean, kind of going along with the idea that if I can diagnose glaucoma earlier, that is better for the patient. And especially as we know in the field of the surgical field of glaucoma, there's been so many advancements in minimally invasive glaucoma surgeries. So now it's pretty much any patient that I'm doing cataract surgery on that's on drops, I'm going to do some kind of surgical intervention. So it's to the patient's benefit if we can really determine, are they stable, are they not stable, and having these tests that continue to improve on itself it's just been so fortunate for us that we as providers can provide that excellent care that our patients deserve.
Excellent. Well, thank you both. I appreciate you for taking the time to discuss how using this technology can increase our efficiency and effectiveness in providing patient care. And we look forward to speaking with you guys again when we talk about developing a more comprehensive glaucoma workflow. So thank you again.
Thank you.
Thank